Thank you all for joining us on Lipid Insights. Today, I'm thrilled to have as my guest Dr. Christie Ballantyne, who is a professor of medicine and cardiology at Baylor College of Medicine and currently the chief of cardiology at Baylor. And Christie's going to talk to us about a document that is going to be published in the coming few days by the National Lipid Association entitled A Focus Update to the 2019 NLA Scientific Statement on the Use of Lp(a) in Clinical Practice. So, Christie, thanks very much for joining us and sharing your insights on what I think is a fantastic document.
Thanks, Alan.
So, maybe you can give us a little bit of background on why you felt an update was needed. I know that the document in 2019 was extremely comprehensive. There were a few controversies around it, but like whether or not everybody should get an Lp(a) drawn, which I think a lot of us believe is reasonable. And it was written sort of like an ACC/AHA guideline. And I found this new document was very readable. It had a lot of information and very clear. But just fill us in on what your goals were and why you felt that an update was necessary.
So, Alan, and the document, it's online, available. It's not in print yet. So one of the things ends up is, we are the National Lipid Association. So I really think that we should be the leaders in the areas of lipids, what to do, and to inform our membership. We've got so many experts in the National Lipid Association. And one of the things would be great is if we're able to come up, this was a wonderful document in 2019, but to have kind of a focused update. I mean, that's 5 years ago. A lot happens in the field. And as you know, sometimes the guideline documents are very, very long. They've got a million, pathways and this and that in them. And it's not the easiest thing for a busy clinician to just, okay, what's in here that I need to know? So our thought was, let's keep this. We don't need to, redo everything. We're just going to focus on what's new, what's changed, and what might be important in your practice.
Yeah, it makes a lot of sense. I know there's been some discussion in some of the other medical organizations about having evergreen guidelines that whenever new information comes up, they get updated electronically. So you don't have to wait 5 years. And for lipid guidelines, who knows how long we're going to have to wait for the next.
That's exactly right. And so it's it's just, I think as an organization, I'm hoping it's something that we can do to have a more of a leadership role. The ACC and ACA, wonderful organizations, and we've worked very much with both of them. They're big, and big organizations take a long time to do things. We're smaller, we're tighter knit, and I think we're more nimble. Hopefully, that we can be out front on some of these things and play leadership roles.
Well, I applaud that. And I think I've always thought a guideline should fit in your shirt pocket. The easier it is to digest, the more likely people will actually follow it. So some of our prior guidelines are fantastic resource documents. They have every detail and they're really more of a source document. And the messages have to be digestible. So I want to dive right into this document because I really do think it's digestible. And maybe start with, what do you think the most important messages are in terms of what you wanted to bring to the table in 2024?
So yeah, we broke it down into kind of what's new, but in terms of why are we changing it. But I think the bottom line ends up is that we have enough evidence now, and there's been a lot of new evidence from the one 5 years ago. There was a lot of concerns that, that the levels are different. For example, if you go to East Asia versus South Asia, or if African Americans or whites, maybe we don't know the right numbers for everybody. So some of the concerns about screening everyone, if we're not sure, I think that we have the data now, and it looks like it's a continuous risk. And if your levels are high, no matter where you're from, what your race is or ethnicity, your risk is increased. So we felt we were in position to say that all adults, so what's an adult greater than or equal to 18 years of age, should have, it would be reasonable for everybody to have at least once in a lifetime a measurement of LPA. And it's always nice when you have a group pediatricians. For some reason, one of the guidelines that said 20, and they said, okay, where does 20 come from? You know, I mean, pediatrics, it's 18. After that, it's your adult medicine. So there's always, the nice thing about our working group. We've got pediatricians, we've got, NPs, PAs, and so people give you that extra, those small details that make it, I think, a little bit more realistic.
Yeah, and if I remember there was a thought that if everyone got it, that they would be pray for unscrupulous folks who were going to put them through all kinds of unnecessary testing. But in reality, we're on the brink of new therapies, at least 3 new therapies that are already in outcomes trials. So it makes sense, even though I think for primary prevention, we're a ways away from what we're going to do with those therapies. Certainly makes sense. And everybody who has family history, who has atherosclerosis, and since it's an autosomal dominant trait, why wouldn't you do one on everybody?
So yeah,
That was your thinking.
yeah. So if you, the other thing is we have if you just look at this document, if you go to table 1, it has all the key data. I mean, it's got, one big paragraph in it, but basically, first of all, if we talk about screening, what are the numbers? And you may get a test that's in nanomoles per liter, which is preferable, but it might be milligrams per deciliter. So we put the numbers down for both. And it's important that, we mentioned in here that if over 125 is considered high. But when the lab test comes back,
For nanomoles, right?
Nanomoles. When the lab test comes back, it's going to say over 75 is elevated. So it's really important. Yeah, it's a continuous variable. So the way that you can think of this, because your patient's going to see that value also. And if you're telling him 125 and it says 75, so the way to think of this is less than 75 is desirable. It'd be like a really good LDL. Over 125 is very high. And you have an intermediate or gray zone in there where there is some concern, but you're not in the level that we would say, as we're thinking about drugs or other major concerns, there is some increased risk. So it's good to know both numbers. Now, if that's milligrams, it's going to be different in that we're talking about 30 and 50. And we include the lower number in here because that's what your lab slip's going to say. That's what your patient's going to see. So it's important that you can instruct them to say, yes, you're in the desired, if it comes back, they have 25 nanomoles. That's great. You're in a desirable zone. We don't need to repeat it. If it's really high, you don't need to repeat it either. There are going to be some people that might be 100 nanomoles, and later on in life, you may want to repeat that. The levels can change. They're not completely immutable. But if it's really low, it's going to always be low. If it's really high, it's almost always going to be high unless there was some kind of acute inflammation or something.
Yeah, it's interesting that the slope of risk really changes its angle right at those numbers, right? 125 nanomoles and 50 milligrams per deciliter. That's where you really see the risk curve start to have a pretty rapid slope upward, right? And below that number, the curve is more flat, or at least your overall risk is not that
yeah,
concerning.
So I think it's that the issue that, so your risk is up, but there's a difference if your risk is up 15% versus 50%. So I think it's, so this is, we went through and looked at it in a primary prevention. We looked at in the ERIC study, and that's a little less than 20%, maybe about somewhere between 15, 18% are going to fall into that high risk category. Secondary prevention, it's higher, and people you should be on statins. They were higher risk to begin with. A lot more of them are going to have high LPAs, and you get about 1 out of 5 people is going to have an LPA that's in the very high zone.
So let's talk about that a little bit. I have heard at a couple of meetings, and it made me a little nutty. So I want to get your insight on this. people worried about the Lp(a) raising effect of statins and saying you should measure it after you put someone on a statin and implying that if it went up, you might want to stop the statin. And I'm not sure if I mean I that goes against everything I've read. So I'd like to hear your thoughts on that.
So, the way I see LPA right now is so we know it's genetic. We know that's very important. It's a genetic risk factor. Now, you can have a risk factor. High cholesterol is a risk factor. LDL is a risk factor. But we've all had patients with FH who never have any problems at all. They have a very clean profile elsewhere, and that's the same with LPA. So it's something that I think it's reasonable if you believe in prevention. Someone should know if they have a high LPA because it influences your lifestyle. I mean, if the dad had an MI at 45 with a high LPA and he's got children, and some of them inherit the high LPA, smoking is not a good idea. And what's an even worse idea, which, I mean, young people are young people. They get somebody with a high LPA in their 20s, they do some cocaine and boom, big MI because it's a vasoconstrictor and they've got plaque there. So these are some things. Why wouldn't you want your children to know that, or their offspring to know that, or their siblings to know these things? In terms of diet, exercise, and particularly, Alan, statins. I mean, it's a little bit the same concept. If someone has a calcium score, if they're 40 years old and they got a calcium score of 10, but they have risk. We put them on a statin. Now, does the calcium get less? No, it doesn't get less. I mean,
Right.
so it's the
So,
same.
so your point is that no one should be worried about statin effect on Lp(a). The
No,
benefit we think would be significant, and they should be on a statin if they've got atherosclerosis. Correct?
absolutely. If you're lowering LDL, 50%. So, it's so if you think about this in nanomoles, so, if you look at LDL particle concentration, someone with a really high LDL might have a particle concentration of 2,000 nanomoles, right? It goes down to 1,000. Could go 1,500 to 750. So you've cleared 750 nanomoles per liter of those particles. What did we say a high LPA was? 150. So you got way more LDL particles in the circulation. So the first thing we do is we knock LDL down, and statins do that extremely well. Yeah, so LPA might go up, 10% or something, but it's a little bit. If your glucose goes up a few milligrams per deciliter, we don't stop the statin. I mean, if it's an LPA is one where it's even less of an effect, I think. So you should, if you're getting so much benefit on the LDL particles, the other
Okay,
important
so
particles.
let's dig into that just a little bit because one of the sections in the paper is that this is actionable. And so what is the data? We all kind of have espoused over the years that in patients with high Lp(a), you want to get their LDL lower. You want to aggressively lower LDL. And I think this first came from either the HATS or the FATS study, which was pretty small studies going back, 30 years. Greg Brown, God rest his soul, papers that suggested that people who had a drop in their LDL didn't have any residual risk from the Lp(a). But I know in Jupiter also there was data that people had their risk attenuated. It wasn't quite as much as if they didn't have high Lp(a). But I'll shut up. I'd like to hear your thoughts on, how strong is the data while we're waiting for Lp(a) lowering drugs to be proven.
So, it's exactly what you said. So what if you had a high LPA in Jupiter, you did have a higher risk. Your risk was reduced. However, the individuals who had a high LPA still had increased risk to the people who didn't have a high LPA. So
Well, the statin helped. It just didn't help as much as you didn't reach as low a risk as you would have if your Lp(a)
yeah,
wasn't high on a statin.
exactly. And so there's been some secondary prevention studies showing similar data. And what's to me even more encouraging is this is just not with statins. We see it with the PCSK9 inhibitors, because both Fourier and Odyssey outcomes show that the people with very high LPAs on statins they were at a higher risk. They got more benefit. They got benefit. Absolute risk reduction was slightly higher because their absolute risk was higher. similar relative risk reduction, but they still had some residual risk because their LPA was still high. So you're helping people. Some of the things that we do in prevention, as I said, when we see high risk, we don't have any therapies. I mean, the chelation didn't work again at the ACC, right? So, it's not like we go send somebody with a high calcium score to chelation therapy. Our goal is not to lower the calcium score. Our goal is to reduce cardiovascular events. And so, treating blood pressure, people exercising, diet, smoking cessation, these are all things that we have very good evidence are beneficial if you have high risk. So we think it's actionable now in terms of general preventive strategies, which our membership knows how to do this. So might as well, we've got someone who got a high LPA, offer this to them and educate them about this. You don't solve all the problems because you didn't really touch the LPA very much at all.
So with that said, Christie, for the people who haven't read the document, and I encourage everybody to read it, it's very readable. I think we get nervous when we hear about a scientific statement that it's going to be, so detailed that it won't be readable. This is a very readable document. If you could just go through the sections of the document, just give people a brief synopsis of what the document incorporates and what they can expect to see in there in terms of the sections. And then I'm going to ask you what you think about the newer therapies and how they may affect future recommendations.
So, we start off with the evidence in terms of why are we coming up with the recommendations. And some of this comes out of UK Biobank, where they have, and a couple of other very large studies where they had more data on also that, that lower, we were talking 75 to 125, and there clearly is some increased risk in that area. So that's one reason why we felt comfortable talking about less than 75 desirable, over 125 high. And you may at some point, if you're going to repeat, that's the group, the intermediate risk is the group that you got one 10 years ago. Women after menopause, it can go up. People get kidney disease, proteinuria, other things that can go up. That it's worth potentially considering a repeat in those people. Conversion factors, they don't really work. So if you got a nanomoles per liter, it's useful. If it's a milligram per deciliter, it turns out those are not too bad on most of the assays. Just use that number. Don't try to do some kind of conversion with it. Now, the other thing that, Alan, that comes up is the data we just briefly touched on, this issue of, aortic stenosis. Keep in mind that data is very strong now. If someone has a really high LPA, you better listen to their heart. You might notice that they've got a murmur there. If they do, get an echo with it. So and to a certain
I
extent,
might interject that they showed it's just observational that it may correlate with even bioprosthetic valve calcification, which I thought was very interesting.
yeah.
I know our structural heart team now is getting Lp(a) on degenerated bioprosthetic valve patients.
I've got a cardiovascular surgeon, older guy who has a porcine valve, and he's like, look, I want to be on a PCSK9 because I want my numbers as low as I can get because it's up. Anyway, the other one is this, there was all this issue about, trying to recalculate the LDL cholesterol because of the LPA level. We don't think that's worthwhile. It's too variable, the amount of LDL per particle with it. And some of the genetic testing for LPA, it's all exciting and interesting in terms of polygenic risk scores and stuff, but basically just measure it. You're going to get the information by the level with it. So in terms of risk assessment, there are a couple of tools where you could end up, calculating the increase in risk. If you're using a risk scoring system, there's one that was published by the ESC, EAS. In general, you and I like to keep things pretty simple. So I just think if someone's got a value that's in the really high zone, you could maybe add about 50% to their risk score with it as a rule of thumb, if you're going to use it as a risk enhancing factor. So that's a section talking about, okay, you've measured it, you can use it in terms of risk scoring. And then we get into the next section, Alan, is about lifestyle statins. Reasonable to lower LDL with PCSK9. It might also be if they can't tolerate a statin or you want to use combination, get it down lower with ezetimibe or bempedoic acid. Neither of those touch LPA levels. So statins don't lower LPA, bempedoic acid doesn't lower LPA, ezetimibe doesn't lower LPA. Niacin lowers LPA, but unfortunately, we don't have the data that when you add it to a statin that you reduce any events. So we don't recommend that. Aspirin is a consideration if they have coronary disease. Yes, we're going to use it anyway. If they had a high calcium score, another consideration to use it. We don't have a lot of data except out of the S5E study, and that was older people who were very high risk, and if they had a genetic marker for high LPA, they had some extra benefit, but it's not very clear. And there is a mention about there is one FDA-approved therapy that is for lipoprotein apheresis. However, it's a pretty strict criteria. High-risk patients with FH and ASCVD whose LPA level remains over 60 milligrams per deciliter, which is around 150 nanomoles per liter, and LDL cholesterol is greater than 100 milligrams per deciliter on maximally tolerated lipid-lowering therapy. So that's the only FDA-approved therapy. So we run through those things, and we, also the two tables, you can look at table 1 and table 3. Table 3 has all the take-home points that I just covered here with it, and you can do that in about 2 minutes, which is about the amount of time you have in a day to look at something for it.
Yeah, that's great. So two things before we get on to just commenting on the new therapies that are coming in. We don't need to necessarily go through them individually, but just the fact that we have therapies that actually lower it for the first time, that lower LP(a) on the horizon. And we'll just have to see if that translates into fewer events. But I'd love your thoughts on that. It has struck me over the years that I have some patients with very high LP(a)s that have rampant progressive atherosclerosis, and their brothers. I have 3 brothers. They've all had multiple bypass surgeries, early graft closures, and just a bunch of cardiovascular events. And then I have other people that come in with high LP(a) that have a calcium score of 0, totally asymptomatic. You are, such a wealth of knowledge with regard to lipid metabolism. Have you had any thoughts why, when we maybe measure the LP(a) levels, that there may be something about particle sizes or the size of the apo(a), or why do some people seem to just totally escape and have nothing? And the bottom line is, when I have a 22-year-old female who comes in because their dad had a heart attack, and she got her LP(a) at the recommendation of her dad's cardiologist. Now it's elevated, no sign of atherosclerosis, and you have to have that discussion with them. What are you going to do? So I just want to get your thoughts on that sort of a dichotomy, and also how good calcium score is in identifying people who are going to do well regardless of the elevated LP(a).
So I think, Alan, this is where, and we see this also with LDL sometimes, where you've got high LDLs and no family history of anything, and yet they all had high LDLs. So in older individuals, calcium scores are great. So, if a man's over 40 or a woman's over 50, I put more weight into it. The younger they are, the more worried I am that they may have soft lac, and I'm missing it, and then I'm giving false reassurance. Now, I still work with a facility that does a really high quality carotid ultrasound, and the report gives me not just an IMT done in a very standardized manner, but it mentions they scan the carotid and they scan the carotid bulb for plaque. Because if I see a plaque in a 22-year-old woman with a really high LPA, and say, okay, listen, I'm sorry, but we better get aggressive early in your life, but lifestyle for sure. We need to start this, depending upon your value and what your dad had or whatever. We may end discussing statin therapy sometime. When to do that, highly problematic. But I think these are the issues. That why is it so variable? That Sam Semikis done along with oxidized phospholipids. I think that's going to be highly variable for each individual. And I personally think you've got, in addition to what's happening on the genetics, with the lipoproteins, you've got differences in genetics in regards to what's happening at the vessel wall and what's happening to your white blood cells. And we've done a lot where some people actually have foamy monocytes when they have high lipids, including this has been reported with high LPA, that the white blood cells actually are taking up some of these lipoproteins, get activated. So we're trying to study more of these to understand. It's we've all seen this. You've got people who have very bad lipids, they have no disease, and you got people who had borderline and they have horrible disease. So it's a complicated disorder with it. So it's in terms of counseling and decision making, it's useful. This is an important piece of data, but you still need to get a history and physical and think about the whole patient.
Yeah, that's a novel idea, but a really important point. So lastly, I guess I'd just like your thoughts on now that we have interventions that lower LP little a 80 to 100%, and with their, they look reasonably safe, though we don't have long-term data, and we've got outcome trials on 3 of them underway. What are your thoughts about that? Number one, are you optimistic that we're going to see outcomes? And then number two, do you think we'll ever have an indication for primary prevention for these patients until they go generic, the drugs go generic?
So I'm optimistic, but I'm a lipid enthusiast, so I'm optimistic. And there's challenges because I know we're involved with all 3 studies, and I mean some of the people in the studies are beautifully treated. I mean they're on every, and they're super educated patients who sought out the study, and they got an LDL of 30, and their blood pressure is perfect, and they're taking something for weight loss, and I mean everything is treated. I'm not sure how much you can reduce the risk in that person. So, I'm a little worried about, adding on. We talk about the high risk patient, but when they've been treated very, very well for everything, how much more risk can we get by reducing LPA? So now one good thing is that the trial that's just getting started now is including high risk primary prevention. And I'm really happy because those people are on a lot less medications. And it may even be to give us a better idea of, okay, what really happens if you're treating LPA rather than someone who's been treated for everything. Maybe one last comment is, and this would be to our membership, and particularly the hat you've worn, Alan, is, I think they looked at some healthcare systems, and I think 6 of them, 0.3% of the population had an LPA checked. Now, we would all agree that's, by whatever criteria, it's too low. So the things that do come up is, how do we implement this? And how do you, if people start testing, they're going to need some education, physicians, on what do you tell patients? What do you do? No, you don't cath somebody because they got a high LPA. I mean, and then also the cost of the test should be low. And it's not always low. These different labs charge different things. So there's a lot of, implementation issues that, people should work out in their practices and in their healthcare system to try to improve how we do this. That's you come up with a recommendation, and this is a new update to basically our NLA guidelines, but how you implement those in practice is very much kind of a local issue.
Oh, I think that's a great point to end on. It strikes me that half the people who've had an acute coronary syndrome are not on a statin at 1 year, and we're all laying awake at night worrying about LP(a) and other biomarkers. This, I think, is so prevalent, right? 20% of the population, that it's important. And I don't mean to de-emphasize that, but as Greg Fonerow at UCLA said, 25 years ago, systems turn good doctors into great doctors. And we need a way to make sure that everyone who walks through our door who should be on a statin is on the statin, while we're laying awake wondering what to do with LP(a). So, and then when we embark on the LP(a) adventure, not to forget all those other preventative therapies that you and many others have taught us over lots of years. So I really appreciate, number one, the work you guys did on that document. I think it's terrific, and it's so readable, and a great update with the latest information. And obviously, there's more to come with new therapies coming out. And everybody should do what we already know while they're waiting for new information. Any final thoughts, Christy?
No, I just, one other thing it is interesting is that they've shown in a couple studies that the people who have an LPA tested are more likely to be taking their statin, and that might just be the self-selection process because they're the ones who are motivated. And but it goes back to the one other point we said earlier is that when you see that, the first thing I even think of is okay, statin therapy, along with lifestyle, uh, and if it goes up a little bit, keep them on the statin therapy. You want to get their LDL down. I mean, so let's not forget the fundamentals because we're excited about something new. It's kind of like don't take your eye off the ball, right, Alan?
Yeah, that's a good point. I don't think you need to reorder Lp(a) when you start a statin on
Yeah,
someone that you're
in general, I don't reorder it because they might get confused or discouraged or something. So I'm just saying, we got it. We're treating you. You're good. Now, when you have drugs available, that's a different situation. But for right now, in general, these people. Some people come in and they want a calcium score every year. No, we're not going to get another calcium score. It's gonna be higher, and they're going to say, "Oh, my statin's not working." No, your statin's working fine.
Yeah, good analogy. Well, thanks very much, Christy. Thanks for the hard work. Thank you for your insights today. And I encourage everybody listening to take a look at this document, which is now online, but soon will be published by the NLA. You should be able to go to lipid.org and look under documents and see it. And in the meantime, have a wonderful rest of your day. Thank you for spending time with us on Lipid Insights.
Thanks, Alan.